welcome to the Resilient Performance Podcast. I'm pretty excited to have here Frank Alexander and partner Trevor Rappa. So Frank works with Dr. Ahmad and his team. And actually I'm going to let you kind of run with it from here and give us a quick intro, kind of your academic background, athletic background, how long you've been with Dr. Ahmad, kind of like what is your normal patient that you guys see, what kind of surgical procedures you do, and just kind of start with that and go where you want.
Awesome. Thanks, guys, for having me. I really appreciate it. And so my background is I'm an athletic trainer. My bachelor's degree is a bachelor's of science in athletic training. I got my master's in kinesiology. And for me, my athletic background, I played baseball and football in high school, and then I was fortunate enough to continue my baseball career in college. So where a lot of my interest has been in baseball, a lot of it due to some of my teammates, some of my closest friends growing up that wound up with these injuries that we see very frequently in the office. So my goal in my life, in my athletic and my post-athletic life, my professional life, has always been to stay around sports medicine and help athletes kind of stay on the field. And if they're not able to, and they wind up with an injury, help them get back to playing at a level that they're happy with, and hopefully help them reach whatever the next level is. So when I was working at the high school level, I wanted to help the kids get to the college level if that was what their aspirations were. And at the college level, you always want to watch those guys, no matter what their sport is. If it's baseball getting called up to the next level, we actually had a couple guys at the college level go to I worked at a D2 school, and some of them went to the Division II combine. So we always wanted to help those kids get to reach whatever goals that they had set for themselves. So I think that's a lot of what we do as professionals too, is making sure that, one, we're able to operate at a level that we want to be at, but making sure the athletes and our patients are getting back to what they want to, whether it's an athlete who wants to play professional baseball, or if it's a grandmother who just had her rotator cuff teared and she just wants to hold her grandkid again. So we treat them all the same. For us in our practice, in Dr. Ahmad's office, I'm one of 4 of his assistants, and we have myself, our nurse practitioner, a nurse, and another athletic trainer, and we all function differently. A lot of what I do is coordinating the care for all of our baseball players and a lot of our patients. So for our baseball players, making sure they get in with excellent physical therapists, such like you guys, and making sure that they're on track, whether it's the constant text messages that the 3 of us are always sharing, or if it's even some of our older patients, just making sure that with their therapist that they're getting the care and they're on the right trajectory.
Awesome. Yeah. And I mean, for an athletic trainer, your job is very atypical. I mean, the typical athletic trainer job is, at a school where you're working. I mean, the hours that athletic trainers are working are ridiculous to begin with. And then, you're working with caring for the athletes yourself, whether it's hands-on or through exercise or whatever it is. You're setting up fields with coolers, like you're doing all of this stuff, coordinating different practice times and a million different things, a million different hats. And your role, I would say, is there's got to be like a 0.5% of athletic trainers that are doing what you do. So I think that's pretty cool. It's pretty unique, and it's cool to see that there's other ways that you can help people. And just sort of talk about how did you even wind up in the role that you're in with Dr. Ahmad, and how did you out of all of the ATs who might be interested, or even non-ATCs, NPs or PAs, people who are interested in sort of this path, how did you find your way there, and how did you find your way there with Dr. Ahmad?
So a lot of what I did prior to working with Dr. Ahmad was exactly that: sideline work after school. And like I said, I did it both at the high school and the college level. Those are 2 separate beasts in and of themselves. The high school, I worked at a school where they actually had a block schedule. So it was similar to a college level academic structure where you had class and it was an hour and a half, and it was only 4 or 5 blocks a day. So you're only seeing those kids a very similar rotating schedule, but I would actually be in during their lunch hour. So if kids needed rehab, I can knock it out there. Or if we were rehabbing an ankle sprain or something that didn't require surgical intervention or higher level rehab, then I would outsource and say, all right, go to this therapist. You got to go see this doc. At the college level, we handled everything 100% in-house. So that was a beast in and of itself. I remember one fall I worked, I think 4 or 5 weeks straight without a day off, 16-hour days during double sessions. It's just a grind.
What sports did you work with in college, Frank?
So got a little taste of everything. During the fall, we had football, women's soccer, and volleyball. But then in the middle of the fall semester, you'd have men's and women's basketball, men's and women's swimming and diving all together. And then you had the non-championship sports in the spring. So men's lacrosse, baseball, practicing, but they weren't getting the same level that the guys that were in their championship season, like the footballs, the volleyballs, they got the full care that they needed because they were in season. And then once we got to the spring, that would flip flop. So spring football always had somebody with them, just because if they were going to Thud or wherever they were going, football just needed help. And then for baseball, somebody was always covering baseball games or practice. I was out there a lot. I took a lot of Florida trips down with those teams. And it's tough in March when you're playing in the Northeast and guys aren't able to get the reps that they need to. And then you fly down to Florida and you get knocked around a bit. So we had, when I remember we played the University at Tampa, and their number 1 was the number 2 at Nebraska the year before. He wasn't happy that he was going to be their number 2 again. And he said, all right, I'm transferring. And he left. And he's the one at Tampa that year. I mean, the kid was a lefty throwing, and he was pumping. This kid was somewhere mid to high 90s. And he wound up getting drafted. So it's 2 different worlds. And depending upon what the needs were, that's where we had to be. And at the college level, I was one of 3 full-time athletic trainers. Wow. We would pick up per diem. In my later years there, we would outsource a little bit more, but at the high school, I was by myself. So I was fortunate that the school wasn't it wasn't a AA school in New York. Everything is A, AA, B, C, D. I'm not sure how it is in New Jersey, what the structure is like, but I had about 400 kids in the school and about 250 student athletes throughout the entire year. Very rare these days, and you guys see it too. There's not too many 2-sport athletes anymore. A lot of them are specializing too young, and we'll get into that, I'm sure, much later on. But the demands weren't as much as the college kids. The college kids, just the way that they were, a lot more soreness, a lot more treatment sessions, a lot more real injuries that we had to manage. So that all set me up for what I'm doing today. And I'm very fortunate to be able to work alongside Dr. Ahmad and take care of athletes from the lowest levels of play to the most elite levels of play. And it's really cool to be able to be in this position and see the differences, not only in the level of play, but in the level of commitment from the kids too, because that can really dictate how much effort that you need to put into them. Because the way that it works, I can't care more than that athlete cares, because if I care too much, then either I'm going to get pushed away or somebody's going to wind up getting frustrated with it. And that's just the reality of athletics in general. But working with the guys,
we've spoken about that for sure, about, you can only care as much as they do, and just, leave the horse to water, so to speak, and hope that they take the advice.
Yeah, definitely. And it's tricky because sometimes it is that catch-22 where you're trying to push them a little bit and you can feel that resistance too, where they're just like, you know what, today's not that day, but maybe tomorrow will be. The professional guys, they want to be out there, and that's why they're playing at that high of a level, is because they're able to grind and they're able to push through. Look, 162 game season is a long year. Spending half of it on the road, obviously this year in the middle of a pandemic is going to be a different story, but still it's going to be a lot in a very short period of time. So it'll be interesting to see where this leads us.
Yeah. And that was something I wanted to bring up too, is the pandemic that we're all in right now and we've all been dealing with. And we could talk about that probably for too long, but what are some, what are you seeing first clinically in the office? Like, what are some things, well, maybe not in the office, more remotely, but like, what are some things that you guys are doing to continue providing care for all of your patients that you've previously seen? I know you guys have stopped, or at a certain point you stopped doing surgical procedures that were elective, of course. And then just recently, I think you've sort of started back up with some procedures potentially. Just kind of talk about in general how the pandemic kind of changed things for you. And then what I'm interested to see, and we've talked about, Trevor and I have talked about this, and Doug, and what are things that are probably going to stick? You know, like what are things that you see as like, oh, this could be useful outside of having a global pandemic to deal with, that we might want to continue doing just because it's going to be helpful for our patients.
We've all learned a lot during this whole situation from you guys and what the capabilities are of a physical therapist, whether it is reducing the hours of in-person contact time, working a little bit one-on-one with patients more, versus how we're able to see a lot of patients and make sure that all of our patients are still being cared for. So a lot of what we're doing, and we shut down everything the day before St. Patty's Day. So all surgery,
Okay.
all in-person visits, with the exception of a couple of different types of injuries or pathologies. So anybody that had an infection, anybody that had an acute fracture or dislocation, those were all still being seen in person,
Right.
just because of the nature of the injury itself. The follow-ups for surgery, if they were seeing a physical therapist, I know Trevor and I have been sharing videos with some of our ACL patients, making sure that they're still doing all right, which has been awesome, and making sure that they are on track. A lot of our therapists at Columbia have been doing virtual appointments as well, just because the facilities, we can open them, but we want to maintain social distancing. We want to follow their parameters as well. It's tough to have, and you guys are seeing it, I'm sure as well, have a high volume and maintain it while you guys have a huge space that you can work with. You still want to make sure that we're all doing right by our patients. It's one thing to be business oriented, but everybody's patient oriented. So
Definitely.
I think what we're going to continue to see is telehealth for follow-ups, because some of that stuff is, you can use a physical exam, and for a lot of our players, our athletes, even non-athletes, it's good even if they're doing a one-on-one session that we video chat during that session. I know Trevor did it with one of our other patients.
Yep.
Dr. Ahmad did it yesterday as well with another professional athlete. So to be one-on-one and do manual strength testing in the middle of it, being able to show off the work that you've done with that patient is really key. I think it's really cool to highlight what you've been doing with them and say, hey, look, this athlete's 8-9 months status post an ACL reconstruction. Let's build it up a little bit more. And you can say, hey, look, this is what we've achieved in such a short period of time. And this is what our next goals are, to make sure that she's running at the 12-week mark. Make sure that she is going to get ready for that. So I
That's
think
a good point. Actually, just
Yeah.
want to talk about that real quick. That was awesome that you just mentioned how like you can have the doctor appreciate what we're doing and like almost have us put on display the things that we've been doing with their patient, with your patient, Dr. Ahmad's patient. Because I think a lot of times, like with doctors or assistants, who aren't like you, or we have our texting relationship, we can easily contact you. If it's a doctor maybe we haven't worked with too much, we might not speak the same language necessarily, or we might not know, the nuances of how different things are working clinically versus, and the expectations might not be aligned. I think that's a really interesting point, and I really hope that we do a lot more video follow-ups, and especially with doctors who don't sort of know what we do, because they might say one thing and we're actually saying the same thing, but we call it something different, or just the terminology and language that we use might be a little bit different. But if we're showing them like this is the thing that we're doing, and they see it and they're like, oh yeah, that's what I was talking about, but I was calling it this, or what. That's just one crude example, but
I think it's such a great way, like even just the examples you're bringing up, Frank, of us to be able to be on the same page, and for the client to understand that they are really getting the best care, like truly coordinated care. Because I would say one of the main, like you guys are obviously the exception, and we have a couple other doctors that are in that same realm where they're so easy to get in contact with. And if we have a question, or if we want to ask them, just something about the patient, or the patient said something, just knowing when follow-ups are, just being able to have a truly continuous plan of care the entire time between us, the therapists, and you guys, like on the real medical side, makes such a big difference. And we definitely have had frustrations where, patients are like, did you talk to my doctor? He said he was going to call you. And it's like, sorry, like I know they're busy, but, patients feel like they're kind of stuck in the middle and they don't really know what's going on. And I think this telehealth world that we're kind of all living in right now really has made a difference in terms of the communication that we're able to have continually.
Yeah, and being able to explain it, we're able to speak a completely different language with medical jargon. And I personally, I see it at home because my wife's a teacher. I'm an athletic trainer. My sister-in-law is an NP. My sister-in-law and I can speak medical terminology in and out, but to have somebody that can put it into more digestible terminology and explain it on another level, that I think is really the more important thing. So where we can disseminate information to our patients, but then on the back end of that, share text messages or hop on a phone call, or these days a Zoom meeting, where you're able to really kind of iron everything out. And my job with our office and our athletes has really been to set it up to a point where I say, look, guys, I'll talk to your therapist. I'll shoot Greg. I'll shoot Trevor a text message and leave it at that. I don't have to worry about trying to find, and I have it like you guys, we have it the other way around. I work with therapists where I'm like, you send them a text message and then the patient goes, did you talk to him? Go a week, 2 weeks go by and you're just complete radio silence on them.
Right.
So that's the tricky part, but it's really the name of the game.
Definitely. And then, so kind of going off of that, Trevor and I were talking about how after some of these surgeries, we'll have patients who will, a lot of times it's a lot of the similar sort of aches and pains and complaints after a UCL surgery that you guys do, a lot of elbows, a lot of ACLs. We'll have these normal aches and pains that we see with everybody. And they're like, yeah, they're normal, they're okay, they're not red flags, they're not even yellow flags. It's
they're
like,
just part of the process.
Part of the process. And you had a major surgery, like this is okay to feel. So that's always something that when I hear something new from people, I'm always thinking in the back of my head, okay, in my mind, I'm thinking, do you feel it repeatedly? Does it go away? Do you feel it only with certain movements? Like sort of things like that. Like, could you just speak a little bit to that side of things post-op when you have follow-ups with people? You can use UCL as an example. You can use ACL as an example. Like, it might be easier to also say, like, what are things that you don't want to hear versus what are okay to, what's okay to hear, because it could be so many different things. But just kind of take that and run with it.
Yeah, so I actually had a phone call earlier this afternoon with a lacrosse player who plays on the U.S. men's national team. He had surgery with us a couple weeks ago. He's a little over 2 months out. So a lot of what I'm looking for in that post-operative course is how long, if you are having soreness, how quickly does it resolve? So let's use a UCL. A baseball player gets back to throwing in about 4.5 months afterwards. So the first time out, we're expecting some level of soreness in there just because you haven't done it in not only 4 months. How long was it when you got your injury, and how long was your injury before surgery? So it's not necessarily you get injured today and then tomorrow you're having surgery. It could be a week, 2 weeks, it could be 2 months before you get injured, have the MRI scan, you try a return to play progression with a non-op UCL, and then you know what, your elbow pain comes back and now you already have 2 months wasted or behind you. I don't want to say it wasted. Everybody's timelines are different.
Right.
But then next thing you know, it's 6 months before you last threw a ball again. So it's like riding a bike where you're going to be able to do it again, but the rehab process, at least the way that we explain with our patient, it's like flying in an airplane. You expect a little bit of turbulence, but if it gets a little bit choppier and you have to make an unexpected landing, that's why the communication between our office, you guys, and we have these spot checks every 8 weeks. And it might be annoying for a patient to come into Manhattan for these spot checks, but it's just to make sure. It's like a train on the tracks. If you get a little bit off course, you're right back on. So that's the more important part. But I think the biggest thing with any type of surgery, whether it's Tommy John, whether it's an ACL reconstruction, my biggest analogy is it's like the stock market. There's ups and downs along the way, but as long as the trajectory is still going in the right way and it's up and to the right, that's the most important part.
Yeah, that's a good way to put it. And I think that makes a lot of sense with patients too.
Mm-hmm.
I think that kind of resonates to kind of boil it down like that. That's a good way to do it. So yeah, you guys do a lot of surgeries, right? You're seeing a lot of injured people. what kind of things are you doing besides, I mean, you've written a children's book you've co-authored with Dr. Ahmad. What sort of things are you guys doing to prevent injury? Because I know you're doing a lot of stuff with that and you're spending a lot of time going through MLB data and just kind of talk a little bit about what you're doing
Yeah,
to prevent injury.
the injury prevention part is actually more important than the seeing the patient part. Obviously, every day brings a new patient into the office with a new type of injury, but trying to keep the kids healthy to me is more important than getting them into our office. While you want to make sure that the kids are getting good and the right treatment, that is paramount at that point in time. But if we can save more arms than we're fixing, that to me is more important than the fixing them, because then you know that you've reached a broader scale. The children's book we wrote is called Understanding Tommy John Surgery and How to Avoid It. And the real purpose of writing that is to open the dialogue between our youth athletes and their parents. You hear, and it's always so sad to hear a kid saying, oh, my elbow hurts, but my coach kept me in the game because I was still throwing hard. That to me is heartbreaking. And it's not fair to the athlete, no matter how old he is, whether he's an 18-year-old where the high school coach is just riding him because he could potentially have a draft in his near future, or if it's a 12 or 13-year-old kid that they're playing in a four game weekend showcase of 2 double headers and they just need an extra arm and they're running thin and they just need to keep them out there. So our goal is to really open the dialogue between the kids and their parents, whether it's in the car ride home or even just sitting at home on the couch watching a Yankee game. Just say, hey, these are some of the warning signs. Are you experiencing any of them? We know that a large majority of kids are playing through elbow pain, so around 75% or higher, and that's why we're seeing the Tommy John rates that we are. They're not a pandemic level, it's an epidemic level, but it's still unsettling to see. The youngest kid I've ever seen that needed a UCL repair, he had surgery on his 12th birthday.
Wow.
So, right. That's what
crazy.
we're trying to avoid. Keep those kids on the field out of the operating room.
Yeah, I think that your point of opening up a dialogue between the parent and the kid is so huge, because I think, Greg, you work with a lot more of them in the office than I do, but, we see that all the time where the kid's hurt, but he wants to keep playing, and the parent wants to let him keep playing because the kid wants to keep playing, or vice versa, where the kid's like maybe doesn't really want to play, but, they have a showcase coming up soon and the parent's trying to get him back on the field, and there's just some sort of barrier between each of them that nobody's really getting to this point. And the athlete is always kind of the one that typically ends up paying the big price for it.
Yeah,
Definitely. And I know, like, for me growing up playing baseball, just as much as you did, Frank, all the way through college, and like I had pain all the time, like I didn't do it the right way. And,
pain all the time.
I just thought it was like, like anything else. It's like, oh, you have to just deal with it. And it's okay if your shoulder hurts here or your elbow's sore there every single time you throw. And like now I'm sure if I go have a catch, like I'd be sore for 2 months. But, like just maybe speak to that. Like I would assume that pretty much everybody that you guys are getting in your office has probably had pain for a long time. Can you sort of, I don't know, like, can you almost put numbers to it, or like, can you figure out like any way to kind of put that into perspective for people and what we're dealing with when we have all these injuries? Because it's happening more and more with younger athletes, that we're seeing more and more of these injuries. And you just said we're seeing a 12-year-old having Tommy John surgery. Like, how does this stop? And I think a children's book is obviously, like, that's an awesome place to start, because I've never seen anybody else do that before. I don't think, and maybe you guys have other examples, but I've never seen a doctor and his team be able to talk in that language and make it something relatable, and that's going to be huge. But like, is it pretty much everybody you see you're expecting is like, yeah, they've had pain for a long time, they've had soft tissue injury for a long time, or are there people who are healthy who are just like, oh, one throw and I'm showing up in your office?
We run the spectrum. So we just saw a kid from a local school in New Jersey who had, this would have been his freshman year spring. He's a Division I pitcher. He's had left shoulder pain since his senior year in high school. So he went to school, had a cortisone injections, and it was very short-lived. So now we're seeing him a year following his injury. So that is one of the and everybody's different. Some people are quicker to pull the trigger. A lot of what we'll see is second opinions. If the initial injury is taking a little bit longer than they were anticipating. Dr. Ahmad being what we call a baseball sports medicine physician, taking care of a lot of youth athletes and even professional athletes, that is really a lot of what we're seeing, is because initially some kids may not they might just go to a local general orthopedist rather than seeing a doctor who specializes in elbow injuries. So that's a big learning curve. Even for me, when I first joined Columbia, I was in the same kind of boat, like, hey, go see an orthopedist, not realizing that, hey, if this is a baseball injury, you should go see somebody that takes care of a lot of baseball athletes. And in New York, you have the guys that take care of the Yankees. So you have the Mets across town, of course, too. So, but my big thing is go see, for baseball players, go see a baseball specialist. And in Trevor's world of ACL reconstructions, you want to see somebody that does a lot of ACL reconstructions. You want to see somebody that takes care of a lot of knees. You don't want to go to a shoulder replacement doctor to have him fix your ACL. While he may be skilled in doing it, but if 90% of his practice is shoulder reconstruction, maybe you go to the guy who does a lot more knee stuff. So there's a fine line in there too. And right. Like I say to a lot of our baseball kids that come in, I had a kid come in from Long Island, 15 or 16 years old. Mom said, "Oh, do I really need to see the Yankees team doctor?" And their son needed Tommy John surgery. I was like, think of it this way. Do you want to see the guy that does probably the most in the country? He's definitely in the top 3. Or do you want to see somebody that does 1 a year that's closer to home and convenient?
Yeah.
If that's me, I want to see the guy that does 5 on a Friday, not 5 in his career, you know? Yeah. And same thing, again, for ACLs. You want to see the guy that's doing a lot of them. And being in New York City, we're in close proximity to a lot of different places. And we even have kids fly in. We had a UCL fly in from Utah, high school kid. So wow. You're going coast to coast. We have international players that will fly in for opinions. That is really what is, to me, an important factor in that kind of thing. So, but back to your question about the timelines, you have some kids, we just did another pitcher probably about 6 weeks ago, right before this whole coronavirus broke out. He had a pop on Sunday, saw his team doc on Monday, had the MRI Tuesday, wound up with the phone call results Tuesday after the MRI scan. We had him on for surgery on Friday.
Which is atypical, right?
Yeah, that's
wow.
very atypical.
It's very fast.
Right.
Yeah, that was super fast for a collegiate athlete. It just right. worked out where he's also a higher draft prospect, so they wanted to make sure that they were getting things in line, so that if his number was called come June, the reality was this was all behind him and he was already on the road to recovery. So,
yeah, and I think sometimes with, we'll see some patients come from local orthos, like you're talking about. Maybe they're not as experienced with a baseball athlete, or a specific type of injury or surgery. And I almost, I don't want to, you can't blame them too, because with insurance policies like that timeline that you just mentioned is not happening with somebody who just shows up to an ortho, a general ortho, who has medial elbow pain and is showing signs of a UCL. I'll often see a kid where it's like, yeah, this, I saw my doctor a month ago and it's not really getting better. And they told me it was tendinitis. And it's like, I don't blame the doctor for not just jumping to, like, you tore your UCL, like, go immediately have an MRI, because oftentimes insurance companies aren't even going to approve your MRI unless you've gone through rehab for a month. So it's like, there's so many obstacles to it. It's like such a layered system that, I wish the timeline that you just described was sort of the norm.
Yeah.
And in certain situations, it can be with a collegiate athlete or a pro athlete, but it's unfortunate that, like, the people who are injuring themselves a lot with these young kids who are getting it more often are oftentimes, like, being delayed in their timeline because of just sort of red tape and some bureaucratic things.
What's like your guys' turnaround, Frank, in terms of somebody coming into the office, you guys determine that the athlete needs Tommy John? What's their typical, time to surgery after that?
We try to keep it under 2 weeks, if possible. Obviously, right now, extenuating circumstances. But in a perfect world, if we saw a kid, today's Tuesday, if we saw a kid on a Tuesday, then we operate twice a week. So we operate Wednesdays and we operate Fridays. Of course, insurance plays a factor into all of that as to where they could have surgery, because we have the hospital, and then we also operate in New Jersey and in Englewood, which is actually, our office is on the first floor of our building, and then our surgery center is on the second floor, which is awesome for us to have everything in one building too.
Right.
But if in a perfect world we saw somebody in the middle of the week, I should be able to get them on for surgery by the end of next week. Especially for our athletes, that is the more important thing. So whether you tear your UCL, your ACL, if you're a football player that dislocates their shoulder and needs a labrum fixed, there is a very finite window of time that we have to get you ready for the next season. So we know that Tommy John takes a year. So the sooner you have surgery, we don't want to compromise longer. Like if we're sitting in May now, we don't want to wait till August, because now you've lost all of spring 2021 and you're going to miss all up until August of 2021. And if that's your junior summer, you just lost your junior summer to get recruited. Same thing for a soccer player or football player that tears their ACL, trying to be able to get that clock ticking anywhere from the 9 months to the year mark. Again, it's a very defined period of time, but using the analogy of the stock market, everybody's kind of up and down. We want to make sure that they're ready. And again, our biggest thing, and I think anybody who works in sports medicine will tell you, that the last thing you want to do is jeopardize 2 seasons for the same injury. So if you need Tommy John surgery, like I said, you want to get it done now rather than wait longer and even have some kind of put next year in some form of jeopardy.
For sure. Definitely. Are you seeing more, like what would you say if you had to pick one age where you see the most Tommy John surgeries that you guys are required to do? What would be the age that you'd pick? What's your average age?
I would say somewhere between junior year in high school and senior year in college. So if you want to pick an age, what is that, 16 to 21?
Yeah. Yep.
If you read the research, it'll tell you, I think 17 to 19. So somewhere between, again, junior year to junior year, maybe. But hopefully by the time
Which makes sense.
Say that again?
Which makes sense. It makes sense when those are the times when, puberty is ending, they're getting stronger. They're almost throwing too hard for their body. Oftentimes, like they don't have the lower level capabilities to do things physically, but they can throw a baseball as hard as anyone else on their team. So you'll find those things kind of catch up to them with that age when they're strong enough to hurt themselves, essentially.
Yeah. Sometimes these kids are growing at such a rapid rate that their bones, ligaments, they're not able to adapt as quickly as they're growing. So you have that end of it. But then once you have these big, strong bones and you still have other things that are developing, it could be maybe they're a little bit more fragile than they're expecting them to be.
Yeah, like it's almost like they're skipping like the evolutionary process and just kind of skipping adaptation. And it's just like, I'm just going to throw 100 miles an hour and I don't care if I don't have the strength to support that sort of thing.
Yeah.
We lost Trevor for a second. He was on his phone. He'll probably plug it in and come back on. Doesn't matter. We could do this without him, but something that I wanted to bring up with you, there was a quote from Dr. Ahmad that I found I think Trevor actually forwarded it to me on social media, and then I kind of sent it over to you the other day. I just want to read one of these quotes. It was from a social media account that Dr. Ahmad had sort of consulted with the MLB in regards to opening the season back up and the potential for injury risk. So he was quoted as saying, "The coronavirus pandemic may greatly compound and exaggerate the risk factors associated with the spring Tommy John surgery spike." So that's something that, we'll see with statistics that May is usually the worst month for Tommy John surgeries. And obviously this year is extremely different. And it's interesting because I could agree with exactly what he's saying, that you should see this big spike and you should be almost worried about this sort of reintroduction of baseball. But at the same time, I can actually almost imagine the flip side of the coin and actually think there'd be less. So I wanted to just talk a little bit about sort of your interpretation of the quote, if you've spoken to him about that topic specifically, and kind of just unravel that. I'm not even aware myself right now, today's the the 12th of May. I'm not aware of what plans MLB has right now, if any, about opening up the season. Do you know anything about that, and then open everything else up?
All I know is what the media knows. And
Okay.
from what I've heard, I think yesterday they came out and said they're talking about a July 4th opening day and spring training being in June. The article, Dr. Ahmad, that you're referring to is actually, Dr. Ahmad wrote a blog about COVID-19 and reinitiation of sports following. So he didn't directly speak to, like, he didn't have a phone call with Rob Manfred and say, hey, you got to be careful. I think it was George King in the New York Post that said that Yankees team doctor warns MLB will see spike in use.
Yeah, so that was my interpretation of how the media put it. So sorry, he did not consult with the MLB. He just put his information out there, and it was grasped and turned into a consultant thing. Okay.
I've actually talked to Dr. Mott a lot about this over the last couple of days, and even as we're seeing from the beginning of this, we didn't know how long this was all going to last and what the post-COVID world was going to look like. Now, as we're getting closer, we have a little bit of a better understanding as to how long guys are going to be able to ramp up for and stuff like that. So I think as we're nearing again, with social distancing, no fans in the stadiums, a truncated schedule, we're still going to see injuries. Look, no matter what sport you're playing, no matter what level you're playing, it is not without risk of injury. So for guys that, and again, for whatever level they're playing at, whether you're a New York Yankee or on your hometown Little League's Yankee team, the important part is you need to still have that ramp up to your season. So a lot of what I've been talking to a lot of people about recently is you have to be opening day ready, even though it's going to be in June or July. You're not mid-season ready. Yeah, you've had a lot of time, but what I think we'll see a lot of is that maybe guys don't break down as quickly because they've had a longer off season. So maybe that World Series hangover for teams isn't as prominent as it has been in the past.
Right. Yeah, and that was something that I was thinking about too. With my initial thought is like, okay, so all these people who are having Tommy John surgery, they're having injuries in May. What is like the type of that athlete? I'm thinking of that athlete as somebody who probably didn't prepare themselves. Obviously, it's preparation aside, you can prepare perfectly or not at all and still be injured regardless. So we're not talking about that. But I would think that the athletes that are probably getting injured in that May timeframe were ones that probably didn't do what they were supposed to do, potentially, leading up to the season. Maybe they didn't throw enough. Maybe they threw too much. Maybe they lifted too much. Maybe they didn't lift enough, or didn't run enough, ran too much. So there's all these different variables. Lots of factors here. But I would think that if you then give that same athlete a few extra months, and hopefully they weren't, just here talking on Zoom to other people, they were actually doing things with a strength coach or independently, throwing with somebody, doing their bullpens, getting their bullpen session work in at a high intensity. And if you're going to do, let's say a once a week bullpen is sort of what I've been recommending for a lot of these athletes so that they stay fresh and sort of ready to go when the time comes. I feel like if you were to do that once a week bullpen at a high intensity and you have all these other factors sort of in a controlled environment, I feel like you can also potentially reduce the risk of injury when it does sort of get to the point when, we're talking about July 4th starting. By then you would have had all of June, all of May, all of April to essentially prepare yourself, as opposed to potentially showing up for spring training in February, end of February, whatever it is, and then only having March to kind of ramp yourself up for April. So I don't know, just an interesting thing in general to think about, and makes you think about just athlete preparation in the big context of how we like to prepare athletes. And just wanted to kind of hear your take on that. But do you have anything else on that topic at all, or what do you think about what my thought process is? I'm an idiot, so I don't know.
Not at all. I think you have a lot of the good principles, and a lot of we're on the same wavelength in that regard. I think some of what I've been talking to our athletes, similar to you, with the one bullpen session a week, is what I've been telling kids. I've been saying, look, throw your regularly scheduled bullpen at your regular effort But then if you want to have a mechanics day or another, like a second bullpen session, maybe make it less, or instead of throwing a 35 pitch pen, throw a 20 pitch pen and work in and out to hitters, or make it a little bit more fine tuning, but don't make it a full effort, all out battle. So you're throwing 2 bullpen sessions. You and I have talked about this multiple times over various off seasons. You're not just going to shut down throwing completely. Marathoners don't just stop training. You know? So for baseball players, they don't need to just stop training. They just have to lower the intensity and the frequency that they're doing it at. They have to be smart about it. They have to have good resources to do it, and not just say, oh, I'm going to throw every day, Monday through Friday from November to February. It's not going to happen, because then that's where you're going to see the biceps tendonitis and all the other lingering things that could have been avoided. So it'll definitely be interesting to see what happens this season with a shortened schedule, with longer off season too, technically, even though they did play games back in March.
Yeah, I guess Trevor's phone.
I was able to,
I knew it.
My phone was like plugged in charging and it still died on me.
Oh, no.
Well, Frank and I were just talking about, baseball coming back, the potential for injury risk either being higher or lower, and how you can kind of argue it either way.
Definitely.
Just depending on, like Frank just mentioned, you could have a longer off season, which potentially could help you out and make you less likely to be injured, or you could have, not be ready if you're having this sort of abrupt, like, okay, we're starting July 4th, and then it's like, you're not either mentally prepared for it, or you don't have the things in place to get ready for it. But I know Dr. Ahmad, like we mentioned, also does a lot of ACL surgeries, which was one reason I wanted to have Trevor on here for sure. Because Trevor, with what we do with Resilient, Trevor is doing a lot of work with change of direction sports, field court sports, basketball players, soccer players, all sorts of change of direction-ish type sports. That's sort of like his expertise for us. So we're always asking him questions, and he's diving deep into that. So I wanted to just bring up ACLs a little bit, have you guys talk a little bit about that. And you can even talk about, the patient you guys are currently sharing, most recently, if you want to. I know you were sending videos yesterday about some stuff. So I don't know, just kind of take it and run with it. Trevor, if you have any questions or whatever.
Yeah, I think, it's interesting because ACL research is kind of all over the place in terms of, what causes it. It can be a lack of hip rotation, too much hip rotation, knee valgus. There's so many different things that, you can kind of, whatever point you want to find as this is a, big risk factor for an ACL injury, you can find some sort of research article that seems to prove that. From what you guys see and your guys, just office in general, what do you think are a couple of the big predictors for ACL injuries?
So actually, to your point about the research, I read something, I think back in college, that said limited ankle dorsiflexion could potentially be in that realm of predisposition. So for us, what we see, the mechanism of injury is typically the same. It's that internal rotation, deceleration, you get that twist, pop, done. Athlete goes down, or maybe they walk off the field going, maybe this just doesn't feel right. In terms of like the makeup of the athlete, it's the quad hamstring ratio is one of the bigger things. You got either you're somewhere there's a deficit, 90% quad, 10% hamstring, vice versa, wherever the athlete falls into. But usually when we're seeing them, their knee has a huge effusion. It's a couple days after the injury, and sometimes it's hard to tell just based off of that guarded exam what they're actually looking like. So as a physical therapist, you're able to see them in the prehab phase, get them down to some level of baseline, get rid of that inflammation, get that huge effusion gone, and then range them, make sure that they have the functional movement to have surgery. So similar to the patient that we're sharing now, she had a big effusion following. We needed to get her into prehab beforehand, and then kind of build her up back to baseline essentially. So she's a little bit more quad dominant, I think, in general. So again, it's the imbalances that is unique to each patient. So I'm not going to take out a goniometer to measure ankle dorsiflexion every patient that walks in here and say, oh, well, maybe this is, maybe this isn't. But I think just a quick visual examination of somebody for my purposes can be sufficient, although I won't be able to put my finger 100% on it.
Yeah, and you shouldn't necessarily have to be able to tease out the cause, because if somebody's lacking ankle dorsiflexion as an example, which could, put them as in a bad position to load their knee, that's something that we should be working on regardless. Like it's a limitation that they have as a human before they're even an athlete. So if you want to walk, you need some dorsiflexion. So like there's things there that we should be addressing regardless, and that's where we need to be looking at everything. So it almost doesn't even necessarily matter. It does obviously, but it's just a matter of like we have to be looking at everything and addressing limitations that we're finding no matter what. So just want to jump in.
And that's a lot of where it comes into in the post-operative phase. Like, hey, these are your balances. There are so many different movement screens out there these days, whether you're the FMS or some type of maybe a sensor movement screen or even a markerless motion analysis. There's so many tools out there. I don't know if the lay population or the everyday, the high school, college athletes, obviously, I'm not talking about Division I. A lot of them are doing movement screens at school. But some of the other, maybe the D2s, D3s, they may have the resources. It's so scattered no matter where you go. It could be a regional thing too. Like I know in New York, there's only one markerless movement screen. It's out on Long Island. I don't know of anybody else between here and Baltimore that has one. So for that is one thing, but a lot of what I rely on if I was on the sidelines, different story. I would want to assess my athletes, see what they're doing, especially high risk ACL patients. I want to know what my football wide receivers are doing, my cornerbacks. I want to see what my volleyball players are doing, because when they're coming down from a jump, our female basketball players, I would tier it based off of the seasonal needs, base it off of the gender really does play a role in that. We obviously see more in female athletes than male athletes. So a lot of that is where I would start. But for my purposes in the office, I leave that to you guys and really let you kind of filter in or out what you need. I think that's the more important thing, and seeing what they need in the rehab, because then you can make a comprehensive rehab program for them. It's not just a paper script. And that's the difference between a good physical therapist and somebody that maybe is a little bit weaker, is you guys are able to fill in the gray and make sure that, hey, if it's not on the script, it doesn't mean you can't do it. I just have to integrate it in the right point in time. I don't have to spell out everything for you guys, but you know what guidelines need to be met and where.
Yeah, that's something I think Greg and I talk about with just all of the post-op people that we see. It's like we want to know what like is completely not indicated at this point in time for whatever reason, whether it's tissue healing, if there's some kind of going on like that, like the running thing, for example, that I'm talking about. It's like structurally, like they may look ready, but or physically they may look ready, but from a structural healing standpoint, is the graft not ready at this point in time for just a higher level stress? And then that's when we have to be playing a little bit more of a waiting game and building up other qualities during that time.
Yeah, it's like we'd rather know exactly what we're not allowed to do. Like, tell me what I can't do, because then everything else I'm going to do based on what a normal progression would be like anyway.
Mm-hmm. Yeah, a lot of in the rehab process, the return to play or return to whatever process that looks like, just because you hit 3 months after an ACL doesn't mean that you're ready to run.
Totally.
You might be able to, but are you functionally able to do it? Is your strength there? Do you have an effusion still? Little things that maybe like just float off the top of your head that you're like, maybe it's a little swollen today, but it's been going back and forth like that for the last month. Doesn't necessarily mean that you're ready. Doesn't necessarily mean that you're not ready. What's your strength? Like there's so many different permutations that go into that it's tricky, and it is so individualized. Like we can use the 9-month mark for return to sport for a soccer player following an ACL. But you look at Adrian Peterson a couple years ago, and I'll put my foot in my mouth.
Exactly.
And bring up that. But it's not that easy to get back to football in 7 months. That's unheard of.
And he was a freak to begin with, right? So like if you take somebody who's a freak before surgery, it's going to be easier for them regardless. And that's what you're talking about earlier with the prehab stuff.
Yeah. Look, and at the professional level, a lot of kids don't see, and even at the college level, the high school level to the college level, college kids are able to put in a lot of time into their rehab. Yeah. High school kids, maybe not so much, but the higher you go in your athletic career, the more resources there are for you and the more time you have specifically to dedicate to your rehab. So the more you put into it, no matter what you're talking about in life, the more you're going to get out of it.
Definitely. Yeah, that's a great point. I think that the time resource is such a huge thing. It's like, why do some people progress faster than others? It's like, if you have the resources and you have the time, and that is literally your job is to get ready for your sport, you're going to be back a lot quicker than if you're a high school kid in class from 8 to 3, Monday through Friday. And then you've got to go to church and all this other stuff on, with your parents on the weekends. You can go to PT for 30 minutes, 2 to 3 times a week. It's like, yeah, it's going to take you a lot longer to get back to your sport rather than the Adrian Pearson example, where he has everybody at his disposal 24 hours a day, 7 days a week for 7 months to get ready to go, play in the NFL.
It could be something as simple as making sure you have an ice compression machine at home.
Yeah, absolutely.
And game readies are becoming more and more available to people, no matter where they're having surgery nowadays. It's there for you. You can have it at home, but if you're not going to use it, it's a wasted resource. And it's not going to shave 3 months off of your return to play timeline, but maybe it shaves a couple days off of your getting your strength back, or something that I'll say is minute comparatively, but it is important in the long run.
Yeah, definitely. Yeah, I think knowing what to emphasize when is such a huge part of that process, for sure.
Any other questions for Frank here? Or Frank, any other questions for us?
Oh, man.
Put you on the spot there.
Yeah, seriously. In terms of like your progressions for whether it's a UCL or an ACL, obviously you guys have no matter who gives you the parameters to go by, you guys, are you able to, who to push harder, who to kind of pull the reins on, but how do you keep those two kids, like this kid you can push hard, this one you can't, and they had surgery near the same time, how do you kind of keep them competitive while rehabbing? And how do you kind of not, I don't want to, you're going to not, you have to be mindful of like how hard you're pushing again, but able to challenge them in the same way so that they're both on the same timeline and they're not pissed off that somebody's ahead of the other.
I think, our situation in Chatham is awesome because we're at a sports performance facility. So when we're working with injured athletes, there's 30 healthy athletes all running around training outside. So I think that just being in that environment really makes people want to work harder. Like with your example, what just comes to my mind is just like, it's more of people that are afraid of certain things and they're kind of afraid of being injured, and it's just really doing whatever we can to build up the trust and explaining to them, like, I'm not going to let you do anything that I'm genuinely afraid of you hurting yourself. We're going to take things as slow as you feel comfortable with, and as long as you feel confident, we're going to keep progressing, and we're building qualities that are going to help you get back to your sport. So like, we have to get strong before we're running. We have to be able to do some plyometrics before we start sprinting and all that kind of stuff. So I think trying to, regardless of the age, and you talk different to, a junior high kid versus a college kid, but just trying to make sure they feel comfortable and are confident in the process and understand like why we're kind of doing what we're doing. I think that really makes just a huge difference. And like telling them like, dude, it's okay to be a little bit hesitant as we start to, move your feet in this way again, just a little bit quicker than you have. And you're so used to having 2 feet on the ground all the time. Like, now I'm going to take one of those feet away. We're going to do some single leg stuff. Like, it's definitely scary at first, but the more you practice it, the more you're going to come comfortable with it. And then things will start taking off from there.
Yeah. And then there's definitely some times where like a patient, maybe they had an expectation of what they were going to be like by a certain time frame. And in their mind, they're almost like worried that they're not there yet. Mm-hmm. And then it kind of goes back to them being afraid too, because if they're afraid and they're not at that point in their sort of progression that they expect to be, then I think they're oftentimes, it's like a perpetuating cycle of being afraid. So I find that, I have patients that are like coming in and out of my mind right now as we're talking about this. And it's like some patients I feel like I can talk more with and kind of explain more about why we're doing certain things. And they should make sense. It should be logical. Like, I've had patients say like, oh, well, I was told I should be running now, but we haven't squatted your, like, anything close to half of your body weight yet. So like, that's probably not a good idea. Like, we need to bring things up and kind of meet your functional sort of like timeline and milestones so that you can run. And doesn't that make sense? Like if you expect to run, you should probably also be able to squat. Like that's a pretty straightforward thing. And then usually it's like, oh yeah, that does make sense, definitely. And it's been so long and we've done all of these other things already that are similar to squatting, so you're definitely ready. And it's just building like a confidence with them. And then I oftentimes find the patients that are asking a lot of questions where they're very they're worried, and their questions are coming from like a worried place or an afraid sort of place in their mind. I try to almost say less and just say like, yes, yep, you're good. Yep, that's awesome. Keep doing that. And it might not be perfect, but it's okay. Like as long as they're exposing themselves to things in a safe way, and I'm not there correcting them and being so picky, because that's going to then perpetuate this thing of like, oh, well, I'm doing my exercises at home and Greg said this and this very specific thing. It's like, I'd rather they did it, 75% perfect and didn't have me in their ear and felt more confident, less afraid, and then they're going to run with it and they're going to just build that confidence as they go. So I think that kind of answers your question.
Yeah, you guys brought up two really good key words there, are expectations and afraid. The psychological aspect of this, no matter what your goals are, can really be debilitating. And for those kids, using two kids that are the same age, it can be a mountain out of a molehill for another kid, and the other kid might wake up the next day and say, all right, I'm ready to get back to doing anything, and they're kind of unfazed by it.
Definitely.
Yeah,
I
I
think you
think
guys
we
are doing
definitely see
research,
that.
right?
What's that?
You guys are doing some research on this stuff right now, aren't you?
Yeah, we are.
You're in the midst of it,
Nice.
so nice way to plug that. And yeah, I mean, if you guys don't have
unintentional.
exactly. So if you don't have anything more to talk about, it's already been over an hour. I won't take too much of your time up. It's been great talking to you. But anything else first before we kind of sign off?
I got nothing. Thanks, guys. I really do appreciate that. This is awesome.
One more question. You got to show us your favorite piece of memorabilia in the room that you're sitting in. I would think it's probably what's right behind you, like showcased with all those signatures on it.
This thing is one of definitely my more favorite pieces. I got so much stuff down here. Actually, I think the most sentimental piece down here that I have is my college jersey that I have hanging up over there. But this thing, if I want to show you the coolest thing, this is probably it, just because it's bigger than Murderer's Row, and it's a lot of MLB greats that we're fortunate to have their signatures on there too.
Yeah. And that's pretty cool. So yeah, Frank gave us a nice little tour of his little man cave here with all of his memorabilia. He's a big Yankee fan. So it's
his
cool
mini baseball Hall of Fame that he has.
Yeah.
In there.
It is a little baseball Hall of Fame for
It's
sure.
not a bad place to be quarantined when you're a baseball guy. That's for
that's
sure.
cool.
And you got a TV over on the side of the room over there, so you're set.
Yeah, it's sitting over here. It hasn't been done that much today, but a lot more work today than play.
There you go. This was great. I think we'll have some good questions potentially that come out of this. We're trying to sort of solicit questions from people as we do these things, because we're doing sort of like little roundtable discussions between Trevor, Doug, and myself. And I think it's just cool because we want to talk about a lot of things that are applicable and like how we actually do things. And we're calling it our Keep It Real roundtable, and try not to overcomplicate things. So it's great to talk to someone who's doing just that, and you're keeping things simple and doing things, you're mastering the basics and doing a good job with your patients. And it's been great working with you, and it makes our lives a lot easier working with someone like you and all the other trainers at the gym in Chatham as well. So
definitely. And guys, working with you guys is awesome as well. The biggest thing for all of our patients, no matter, or just patients in general, is you just got to make sure that they have good communication between the offices. I can't overstate that enough. And that is really, patients love that there is over communication, then other patients don't like that there's over communication, but everybody needs to be on the same page and make sure that we're all doing what's best for the patient.
Absolutely. Yeah. That's always the goal.
Yeah.
Awesome. Well, keep on keeping it real. And thank you.
Thank you, Frank.
Definitely. Guys, thanks for having me. I'll talk to you guys soon.
All right. Take it easy.
Bye.
Thank you for listening to the Resilient Performance Podcast. As a thank you for listening, we'd like to offer a 10% discount on our online products, which you can find at resilientperformance.com. We'd like you to use the promo code PODCAST, PODCAST, to get the 10% off. Right now we have the Resilient Movement Foundations course online format for you to purchase there. And we hope to grow that soon before the end of the year and have some other offerings. We hope you enjoy. Again, that's promo code PODCAST, PODCAST, for 10% off. Thanks.